Imagine walking into a trauma bay. The monitors are screaming, the lights are blindingly bright, and like a team of 6 people is working frantically on a patient.
Right, a patient who can't speak, can't point to where it hurts, and might not even be fully conscious.
Exactly. And there's this popular perception, driven mostly by television, I think, that medicine in these moments is just a series of brilliant, isolated flashes of insight.
Yeah, like a doctor looks at a monitor, yells out a diagnosis, and suddenly everything is perfectly clear.
But that's just TV magic. Welcome to the deep dive, everyone. Today we're opening up a stack of incredibly rigorous, high stakes clinical files.
I mean, we've got raw case studies, nurses' notes, shifting vital signs, and split-second triage scenarios pulled from the absolute bleeding edge of pediatric emergency and chronic care.
And our mission today isn't just to memorize what to do, we want to understand the intricate, unforgiving logic of the human body.
Right. We want to know exactly what is happening at the cellular, chemical, and mechanical level. The
Mhm.
stuff that makes one decision a lifesaver and another a fatal mistake.
So, to you listening right now, consider this an invitation to put on your clinical detective hat. We are going to navigate these murky waters together.
And to do that properly, we have to start with the fundamental physics of staying alive. In any crisis, you always start with the ABCs: airway, breathing, circulation.
Right, because if you don't have an airway, nothing else matters at all. Like the brain starts dying in minutes. So, let's pull up our first clinical file.
Let's hear it.
Okay, it's a Friday night, 10:45 p.m. An adolescent is rushed into the ED after a motor vehicle crash, and the paramedic handoff sounds, well, relatively reassuring at
Oh,
first.
those are always the tricky ones.
Yeah, the kid was conscious at the scene, the airbag deployed properly, they were wearing their seatbelt, and the initial vitals reflect that stability. Heart rate 94, respiratory rate 20, blood pressure 100 over 60.
But, I mean, medicine is about trajectories, not snapshots.
Hmm.
A stable trauma patient is honestly just a patient who hasn't decompensated yet.
And decompensate they do. By 11:00 p.m., so just 15 minutes later, the trajectory totally plummets. They suddenly report sharp, stabbing chest pain, like a 6 out of 10.
Okay, that's a massive red flag.
Right. Their breathing shifts from normal to fast, frantic, and super shallow. The nurse listens to the chest and hears diminished breath sounds on the entire left side. And the oxygen saturation monitor starts alarming.
So that rapid 15-minute shift is the absolute textbook presentation of a developing, potentially lethal pneumothorax.
Let's build a visual here for the listener because, pneumothorax is a pretty dense clinical term. I always kind of picture the respiratory system as a balloon inside a rigid box.
That's a really good way to look at it.
Yeah, the chest cavity, the ribs, the sternum is that unyielding box. The lung is the balloon inside. Normally, it fills the box completely, but in a high-speed crash, that blunt force trauma can physically tear the spongy tissue of the lung.
Right, the balloon springs a leak. And the lung is surrounded by the pleural space, which is basically a microscopic gap between the lung tissue and the ribcage wall.
And there's supposed to be a vacuum there, right?
Exactly. Normally, there is negative pressure there, keeping the lung pulled open. But when the lung tears, every time the patient takes a breath, air escapes out of the lung and dumps directly into that pleural space.
And because the chest wall can't expand outward, that pressure has to go somewhere, so it goes inward.
Yes, it actively crushes the lung it just leaked out of. The lung collapses inward. And this is exactly why the patient's breathing gets fast and shallow. They physically cannot inflate that left lung against the trapped air.
Which perfectly explains why the nurse couldn't hear breath sounds on the left side. They're just listening through a dead layer of pressurized gas.
Exactly. So the immediate actions are twofold. First, slam on high-flow supplemental oxygen. And second, prepare for a chest tube insertion.
Because the oxygen is just a temporary measure, right?
Yeah.
Since they lost half their gas exchange surface area, the brain is starving.
Right, it's a state of hypoxia.
Mm-hmm.
By applying 100% oxygen, you supersaturate the air going into the one good lung while you fix the plumbing.
And the chest tube is the plumbing fix. They basically shove a plastic tube through the chest wall into that space to vent the trapped air.
Yeah, the moment that tube breaches the space, the pressure equalizes, and the lung literally reinflates like a parachute.
Okay, but here's where the case file gets fascinating. It gives us the incorrect actions. One of them is place the adolescent in a supine position, meaning lay them flat on their back. Why is laying a trauma patient flat so dangerous here?
It comes down to gravity and the diaphragm. Your diaphragm is this massive muscle at the bottom of your chest. When you sit up, Gravity pulls all your heavy abdominal organs, the liver, the stomach downward, giving the diaphragm room to drop.
But if you lay them flat,
If you lay them supine, all those heavy organs slide upward and rest their weight right against the bottom of the diaphragm.
Oh, wow.
Yeah, you're forcing a patient with only one working lung to basically bench press their own liver with every single breath. It massively accelerates respiratory failure.
okay, another wrong option that caught my eye. Obtain consent for a paracentesis. Now, a thoracentesis is a needle in the chest, but a paracentesis is a needle in the abdomen, right?
It is, and choosing that would be a catastrophic error. A paracentesis is for draining fluid from the belly, usually in liver failure. Our patient has an air leak in their chest.
So it's literally the wrong half of the torso.
Plunging a large needle blindly into the abdomen of a trauma patient who doesn't need it is a fantastic way to perforate an intestine or lacerate a spleen. You cause a massive internal hemorrhage.
And you're completely ignoring the collapsed lung. The last incorrect option is an albuterol inhaler. If a kid can't breathe, an inhaler sounds intuitive, right?
It does, but you have to match the pharmacology to the pathology. Asthma is a problem of airway constriction. The pipes are spasming shut. An inhaler chemically forces those pipes to relax.
But our car crash patient doesn't have spasming pipes. They have a lung being crushed by trapped air from the outside.
Right. It's like trying to fix a garden hose that has a heavy boulder sitting on it by pouring pipe cleaner down the inside. The inhaler will do absolutely nothing to remove the boulder.
That makes so much sense. Okay, let's pivot from the brute force trauma of a car crash to the microscopic trauma of an illness. We have a clinical file for an infant with moderate croup.
Croup. It's a brilliant, vicious example of how a child's anatomy works against them. It inflames the subglottic space, the anatomical bottleneck, just below the vocal cords.
And a 6-month-old infant's airway is maybe the diameter of a drinking straw.
Exactly. If you add just 1 millimeter of inflammatory swelling to the inside of that straw, the resistance to airflow doesn't just double, it increases exponentially.
Which explains this brutal presentation. The infant is extremely irritable, has a hoarse cry, that classic seal-like barky cough, and stridor.
That harsh, high-pitched whistling sound.
Yeah, and a respiratory rate of 78 breaths per minute, plus severe retractions, oxygen at 89%, and oddly, the infant hasn't peed in over 12 hours.
What you're describing is an infant in the absolute final stages of compensatory respiratory distress. They are exhausted, and they are suffocating.
So the team throws the kitchen sink at it, 4 fluids, cool mist oxygen, racemic epinephrine. We skip ahead a few hours, and the file notes 4 victories.
Okay, what are they?
The infant is sleeping soundly, oxygen is 96%, there are clear bilateral breath sounds, and they finally produced a wet diaper. But let me push back on that first one. Isn't a baby falling asleep just a sign they've totally exhausted themselves? How is that a victory?
It is one of the most terrifying calls a pediatric nurse has to make. Is the child quiet because they're better or quiet because they're dying?
Right.
To understand why it's a victory here, look at the initial presentation. Profound irritability. Unexplained restlessness and thrashing in a pediatric patient are flashing red light indicators of hypoxia.
Because their brain is suffocating and triggering an alarm.
Exactly. The brainstem unleashes a massive fight-or-flight adrenaline surge. The child is thrashing because their body chemistry is screaming that they're dying.
Wow. So when the epinephrine finally works?
The epinephrine rapidly shrinks the swollen tissue, opening the airway. Oxygen floods the lungs. The brain gets the oxygen it was craving, and the alarm turns off. They fall asleep because the chemical terror has ended, and they finally feel safe.
The absence of panic is the proof of oxygenation. That is profound. And the bilateral breath sounds mean the air is successfully navigating all the way down to the deep alveoli again. But what about the wet diaper? Why do we care about pee when treating a swollen windpipe?
Biological systems don't operate in isolation. Breathing 78 times a minute means blowing off massive amounts of invisible water vapor. They get profoundly dehydrated.
The tank runs dry.
And the body is ruthless when the tank runs dry. It clamps down on blood flow to the kidneys to save the heart and brain. The kidneys just shut down urine production.
So when that diaper finally turns blue,
it means the IV fluids replenish the blood volume, the heart is pumping strongly again, and the kidneys woke back up. It's proof the systemic crisis is averted.
Let's stick with the airway for a minute and look at epiglottitis and pertussis. The file warns against an incredibly dangerous, incorrect option for epiglottitis, obtaining a throat culture. Why is sticking a swab down a kid's throat so catastrophic?
The epiglottis is that little flap that acts like a trapdoor over your windpipe when you swallow.
Yeah.
In epiglottitis, it gets massively infected and swells up like a cherry.
Obstructing the airway.
Right. But worse, the inflammation turns it into a hair trigger trap. If you touch it with a swab, the brain interprets it as a massive aspiration threat. It fires a violent reflex,
A spasm.
a laryngospasm.
Yeah.
The vocal cords and that swollen epiglottis instantly clamp shut, forming a 100% impenetrable airtight seal. The child will arrest in front of you.
Good Lord. Note to self, leave the cherry alone. What about pertussis or whooping cough? The immediate intervention is droplet precautions.
Pertussis is fascinatingly destructive. Your respiratory tract is lined with microscopic, hair-like cilia that constantly sweep mucus up and out of your lungs.
Like an escalator for trash.
Precisely. The pertussis bacteria attach to those cilia and release toxins that paralyze and shred them. The escalator stops.
So the mucus just builds up.
Massive amounts of sticky sludge.
Okay.
The only backup system is the cough reflex. They have these violent coughing fits trying to blast the mucus out, and every cough aerosolizes millions of infectious droplets. Droplet precautions are mandatory.
We have one final airway case, anaphylaxis. The priority action is to administer epinephrine IM intramuscularly. Let me challenge this. If a kid is crashing and in shock, wouldn't you want to establish a massive IV line first so you can pump them full of fluids directly into the blood?
It's a logical question, but it's a trap. To understand why IM epinephrine is king, look at what histamine does during anaphylaxis.
Okay, histamine causes the bronchoconstriction, the airways clamping shut.
Yes, but it also causes massive systemic vasodilation. All the blood vessels in the body suddenly widen and become leaky.
So the blood pressure plummets to near zero.
Exactly. Distributive shock.
Ah.
And because the pressure craters, the veins in the child's arms physically collapse. They flatten out like deflated balloons.
Oh, so you can't even find a vein to put the IV in.
Right. You might spend 10 or 15 minutes blindly digging with a needle, and in those 10 minutes, the airway completely closes. You don't have time.
But with an IM injection.
You bypass the veins entirely. You jam the autoinjector deep into the thigh muscle. The tissue rapidly absorbs it. The epinephrine hits the receptors, instantly reversing the vasodilation to drive blood pressure back up and relaxing the airways so they can breathe.
Treat the failure first, then build the IV infrastructure. Makes total sense. Okay, let's pivot. We've secured the airways. But what happens when the delivery vehicles themselves, the blood cells, are structurally compromised? This brings us to a complex triage puzzle.
Triage is the ruthless art of deciding who gets saved immediately based on the mechanism of injury.
Right, so we have 4 patients. Patient A has sickle cell anemia and reports decreased vision in their left eye. Patient B has cystic fibrosis with a non-productive cough. Patient C has asthma in the green zone. Patient D has bacterial meningitis with a headache and light sensitivity. Who gets seen first?
Without a second of hesitation, patient A, the child with sickle cell and the vision complaint.
Okay, devil's advocate. Patient D has a brain infection. Bacterial meningitis. Why does a kid with a blurry eye beat out a brain infection?
We have to zoom way in on the molecular structure of the blood. Normal red blood cells are flexible, squishy discs that slide effortlessly through microscopic capillaries.
But in sickle cell,
There's a genetic mutation. Under stress or low oxygen, the hemoglobin inside crystallizes into long, rigid rods. It warps the cell into a hard, sticky sickle shape.
and hard, sticky things don't flow well.
They snag on vessel walls and clump together, creating a massive logjam of dead cells. A vaso-occlusive crisis. Now, apply that to the eye. The retina is fed by incredibly delicate microscopic arterioles. If they're losing vision, a logjam just blocked the central retinal artery.
So the retinal tissue is actively suffocating right then and there.
Yes, ischemia.
Yeah.
If that nurse doesn't push aggressive IV hydration and oxygen immediately to flush those sickled cells out, that retinal tissue will die permanently. They will be irreversibly blind in an hour.
Wow, it's a ticking clock of tissue death. But what about the meningitis patient?
Meningitis is life-threatening, but triage is about the unexpected versus the expected. A headache and sensitivity to light are the classic baseline expectations of meningeal irritation. The disease is acting exactly how we expect. The sickle cell patient is actively losing an organ.
And obviously, the asthma kid in the green zone is fine, and the CF kid with a cough is basically just experiencing a normal Tuesday. Right?
Exactly. A chronic cough is their baseline state as they try to clear that thick mucus.
Okay, let's stay with the blood. We have a toddler with hemophilia who took a hard fall on the playground. Hemophilia is a failure of the blood's ability to clot, right?
It's a genetic deficiency in the coagulation cascade. When a normal person bumps their knee, platelets rush to the site and form a loose, temporary plug.
Like throwing sandbags into a breached dam.
Yes, but you need concrete to hold back arterial pressure. The body activates clotting factors to weave a strong net of fibrin fibers over the platelets, sealing it permanently.
And hemophiliacs are missing the concrete.
Usually factor 8. The platelets form the loose sandbag plug, but the body can never pour the concrete. The bleeding into the tissue just continues.
Which explains the toddler's knee. It's massively swollen, covered in deep bruising, and they are in excruciating pain. They're bleeding right into the joint capsule.
Acute hemarthrosis. Blood doesn't belong inside a joint. The iron and enzymes are highly toxic to cartilage. It will literally erode the joint, leading to permanent, crippling arthritis in a toddler if not stopped.
So they administer 5-factor 8, apply ice, elevate it, and give morphine. But the file strictly forbids performing passive range of motion exercises during the first 12 hours. Wouldn't you want to gently bend the knee to keep it from locking up?
It's a well-intentioned mistake that destroys joints. Think about the microbiology. We just gave them factor 8. The body is desperately trying to assemble microscopic, fragile threads of fibrin to seal the torn blood vessels.
It's wet concrete.
It is wet concrete. If you physically bend their knee back and forth, the torque and grinding will literally rip apart every single fragile fibrin thread the body just laid down.
You'd turn a microbleed right back into a macrobleed.
Exactly. The joint must be totally immobilized for the first 12 to 48 hours.
There's also a rule here about pain management. We must avoid aspirin and NSAIDs like ibuprofen. Why?
NSAIDs reduce inflammation, but they also inhibit an enzyme necessary for platelets to become sticky.
Wait, so if you give them ibuprofen, you take away the platelets' ability to stick together, you make the sandbag smooth.
Exactly. You chemically disarm the only working part of their coagulation cascade. You basically guarantee they will bleed to death into their joint. You have to use acetaminophen or opioids instead.
Let's round out the blood section with anemia. A school-aged child comes in with profound fatigue and tachycardia. The indicator is a low hematocrit level, and the fix is feeding them half a cup of raisins. What exactly is hematocrit?
It's a measurement of blood density. If you spin a vial of blood in a centrifuge, the heavy red blood cells sink to the bottom. Hematocrit is the percentage of the tube taken up by those packed red cells.
The ratio of solid delivery trucks to the liquid highway.
Right. If a hematocrit is 24%, the highway is mostly empty water. The brain and muscles are running on a fraction of the necessary oxygen, which causes the profound fatigue.
And the high heart rate.
The brain tells the heart, we only have half the delivery trucks, so pump them twice as fast to make up the difference. The heart exhausts itself.
And the raisins.
Raisins are a dense source of iron. By feeding them raisins, you deliver raw iron to the bone marrow factory so it can finally manufacture new red blood cells and raise the hematocrit back to normal.
Okay, we are moving into a massive section of our dive now. Sometimes blood issues aren't genetic, sometimes the threat is environmental and it hides in plain sight. We're looking at lead poisoning.
This case is a masterclass in how pediatric nursing extends way beyond the hospital bed.
Here's the setup. A toddler is brought in for well child check. The parents say they recently bought an older, unrenovated urban house and are tearing down walls. They also mentioned the toddler is a very picky eater, mostly living on crackers and juice, and is suddenly lethargic with pale pink mucous membranes.
Okay, there's so many clues there.
Right. The file says this child is at extreme risk for irreversible intellectual deficits and decreased kidney function. How do an old house, a diet of crackers, and pale lips combine to destroy a brain?
The invisible culprit is lead dust. Homes built before 1978 used lead-based paint. When you renovate and sand old plaster, you aerosolize decades of lead into an invisible dust.
And the toddler crawls on the floor and puts their hands in their mouth. But what about the picky eater detail? Why does that matter?
It is the physiological multiplier. Lead is a biological imposter. At a molecular level, it looks and acts incredibly similar to essential minerals, specifically calcium and iron. A picky eater living on crackers is profoundly malnourished. They are starving for calcium and iron.
So their body is screaming for minerals.
Desperately. The intestine builds millions of extra transport doors, leaving them wide open. When the lead dust enters the gut, these hungry receptors mistake it for calcium and eagerly shuttle it straight into the bloodstream. A well-nourished child might absorb 10% of ingested lead. A malnourished child absorbs up to 50%.
That's insidious. The body's own starvation response smuggles the poison in. So what does it do in the blood? Why the pale lips?
The pale lips are lead-induced anemia. Lead seeks out the bone marrow and violently binds to the enzymes that synthesize hemoglobin. It literally shuts down the red blood cell factory.
And the brain damage.
Because it entered disguised as calcium, it easily crosses the blood-brain barrier. In a toddler's brain, calcium is the master switch for neurons to form new learning pathways. The lead wedges itself into those calcium channels and blocks them. Neurons misfire, synaptic connections wither, and it causes irreversible drops in IQ and severe learning disabilities.
So how do we fix it? The interventions say we address the blood lead level first with a drug called Suxamer, and then address the anemia later with an iron supplement. Why wait on the iron?
Because you can't rebuild a house while it's still on fire. Suxamer is a chelating agent. It acts like chemical claws in the blood, hunting down lead ions, grabbing them, and forming a heady complex that the kidneys can filter into the urine.
You're physically ripping the metal out and peeing it down the drain.
Exactly. But chelation is chaotic. If you give iron at the same time, the Suxamer claw might grab the iron by mistake. You waste the drug and leave the poison in the brain.
Now, let's look at the incorrect options for this case. One was restrict oral fluids, and another was limit intake of calcium-rich foods. Why is fluid restriction lethal here?
Because the kidneys are filtering out those heavy, toxic lead-chelate complexes. That requires massive, continuous fluid pressure to flush them through the microscopic renal tubules. If you restrict fluids, the river dries up, the complexes crystallize inside the kidney, and you cause catastrophic renal failure.
And limiting calcium is terrible because lead and calcium compete for the same doors in the gut, right?
Exactly. You want to flood the child's diet with high-calcium foods like milk and cheese. You saturate the gut so every receptor is full of calcium, effectively locking the doors so any newly ingested lead just passes harmlessly out in the stool.
The discharge teaching ties it all together. Offer orange juice with the iron pill, sprinkle Suxamer on applesauce, and use a wet cloth to dust the house, never a dry duster.
Right, the vitamin C in the orange juice chemically multiplies iron absorption in the gut. And a wet cloth traps the heavy metal particles in the water tension so they don't just get launched back into the air for the toddler to breathe.
It's all practical biochemistry. Okay, we're shifting gears from environmental toxins to the nervous system. Acute mechanical trauma.
The brain is the master control room. When it takes a hit, the shock waves cause bizarre failures in completely unrelated organ systems.
Case 1 proves that. A 10-year-old with a severe head injury. The nurses have to monitor for diabetes insipidus, indicated by an unexplained increase in serum sodium levels and mental confusion. What does diabetes have to do with getting hit in the head?
It's just an unfortunate quirk of medical naming. Diabetes mellitus is the sugar one. Diabetes insipidus has nothing to do with sugar. It's a catastrophic failure of the body's water management system.
And the master control for water is in the brain.
Yes, the pituitary gland. I think of it as the master water dam. It sits at the base of the skull, suspended by a fragile, incredibly thin piece of tissue called the infundibular stalk.
Which sounds super vulnerable in a car crash.
It is. The pituitary releases antidiuretic hormone, or ADH, which tells the kidneys to reabsorb water and hold it in the blood. But when the gelatinous brain violently slams back and forth in the skull, it shears and snaps that fragile stalk.
The dam manager gets knocked out.
The dam breaks. Without ADH, the kidneys become completely incapable of holding onto water. They just open the floodgates. The child will produce liters upon liters of totally dilute urine in hours.
Which explains the spiked sodium level in the lab.
Hypernatremia, yes. They aren't gaining sodium, they're violently losing all the water that dilutes it. The blood turns into this thick, concentrated sludge packed with sodium.
And dense sodium exerts a massive osmotic pull, right? Which leads to the mental confusion.
Exactly. It physically sucks water directly out of the neurons in the brain to try and dilute itself. The brain cells dehydrate and shrink, the synapses misfire, and it causes profound confusion, lethargy, and eventually a lethal coma.
It's a terrifying, unbroken chain of dominoes. Let's look at another head trauma. An infant with a skull fracture and an epidural hematoma. The absolute first action is implement strict seizure precautions. Why does an epidural hematoma guarantee a seizure?
Anatomy of the bleed. The brain's outer protective layer is the tough dura mater. Right next to it, embedded in the skull, is the middle meningeal artery.
An artery, not a vein. That's a fire hose.
When the skull fractures, the jagged bone shears that artery in half. High-pressure arterial blood blasts out, acting like a hydraulic wedge tearing the duramater away from the skull. It creates a rapidly expanding pocket of blood.
And since the skull is solid bone, that blood pocket pushes inward, crushing the brain.
Right. It pushes forcefully down on the cerebral cortex, which is full of neurons firing delicate electrical signals. That severe localized crushing pressure severely irritates those neurons.
They start misfiring wildly.
It creates a massive, uncontrolled electrical storm across the surface of the brain. The physical manifestation of that storm is a full-body seizure. Seizure precautions aren't just safety, they're anticipating the near-certain result of the brain being crushed.
While we're on the nervous system, let's look at a lumbar puncture. The nurse has to apply EMLA numbing cream to the spine exactly 1 hour prior to the procedure. Does a numbing cream really take a full 60 minutes to work?
It's the unyielding pharmacokinetics of transdermal absorption. If a dentist injects lidocaine with a needle, it hits the nerves instantly. But EMLA cream is applied on the outside of the skin.
And skin is evolved to keep chemicals out.
It's a biological fortress. The outermost layer is a dense, impenetrable brick wall of dead cells and keratin. The anesthetic molecules have to slowly, painstakingly seep through those layers to reach the deep nerve endings. That journey takes a minimum of 60 minutes.
And if you wipe it off at 30 minutes?
Only the top layers are numb. When the large bore needle hits the deep tissue, the patient will feel agonizing pain. And during a spinal tap, if a patient feels sharp pain and flinches while a needle is millimeters from their spinal cord.
Catastrophic nerve damage. Okay, wait the full hour. Let's transition to the messy chemistry of the abdomen, post-operative puzzles. We have a school-aged child 24 hours post-op for a routine appendectomy.
This is all about recognizing the subtle signs of systemic collapse.
Right, so immediately after surgery, everything is normal. But 24 hours later, the chart explodes. Temperature spikes to 38.6 Celsius, pain is 8 out of 10, breathing is rapid and shallow, the abdomen is rigid and distended, and the white blood cell count jumps from 16,000 to 24,000.
That screams one word: peritonitis. A massive intra-abdominal infection.
What went wrong inside?
The appendix is packed with infectious feces. The surgeon cuts it off and staples his gum closed. But if that staple line leaks...
Oh no, toxic fecal matter spills into the sterile peritoneal cavity.
It's like a sewer main bursting in a hospital clean room. The immune system detects the invasion and the bone marrow churns out millions of attack cells, hence the massive white blood cell spike. The inflammatory cytokines trigger the raging fever.
But why is the abdomen rigid? The common term is a board-like abdomen. Why does it feel like a piece of wood?
It's an involuntary defense mechanism. The lining of the abdominal wall is rich with sensitive nerves. When bathed in infected fecal fluid, any movement causes blinding pain. The brain's motor cortex sends an unyielding command to the heavy six-pack muscles to forcefully contract and lock down.
They turn into a physical shield to splint the abdomen and prevent the organs from moving.
Yes, and the splinting explains the rapid, shallow breathing. When you take a deep breath, your diaphragm pushes down into the abdominal cavity. If that cavity is a swollen cauldron of peritonitis, pushing down causes agonizing pain.
So they just take tiny sips of air to avoid pressing on the fire in their belly.
Exactly. Now contrast that with case 2. A 6-year-old immediately post-op for a ruptured appendix. The file says an expected finding is hypoactive bowel sounds. Why are quiet bowels healthy here? Because of the massive insult the gut just endured. The surgeon had to physically handle and retract the intestines, which are lined with delicate nerves. That physical trauma, plus the paralytic anesthetic drugs, completely stuns the bowel.
It turns off the conveyor belt.
It triggers a paralytic ileus. The brain shunts blood away from digestion to focus on survival. So you shouldn't hear the constant gurgling of a working gut. Hypoactive sounds prove the gut is resting and slowly rebooting.
Let's stick with the abdomen. A preschooler with a Wilms tumor. The file has a bold directive. Do not palpate the abdomen. Never press on it. Why?
A Wilms tumor is a highly aggressive kidney cancer. But unlike tumors that send out tendrils, it encapsulates itself. It creates a fragile cellophane-like membrane holding millions of malignant cells tightly packed inside a pressurized ball.
It's a water balloon full of cancer.
Precisely. If a nurse aggressively presses deeply into the abdomen, the sheer pressure can easily pop that fragile capsule. Millions of cancer cells will explode outward, seeding themselves throughout the sterile peritoneal cavity.
You'd turn a treatable localized cancer into a massive stage 4 metastasis instantly. Do not touch the belly. Got it. Moving to section 6. Systems management. Kidneys, heart, and GI.
Let's untangle these 3 devastating kidney failures based on their labs: nephrotic syndrome, APG, and HUS.
Okay, nephrotic syndrome is linked to massive fluid swelling and astronomically high blood cholesterol. What does fat in the blood have to do with a kidney filter?
It's a fascinating chain reaction. In a healthy kidney, the capillary walls of the microscopic filters, the glomeruli, have a strong negative electrical charge. Blood proteins like albumin also have a negative charge, so the filter magnetically repels them, keeping them in the blood.
Like two negative magnets pitching away.
Right. But in nephrotic syndrome, an autoimmune attack strips that negative charge away. Suddenly, gaping holes open up, and the kidney dumps colossal amounts of albumin into the urine.
The blood loses its protein. Why does that cause swelling?
Albumin acts as a molecular sponge, providing the oncotic pressure that holds water inside the blood vessels. Without it, the water just seeps out through the capillary walls into the tissues, causing massive whole-body edema.
Okay, swelling makes sense, but the cholesterol.
That's the liver panicking. The liver senses this massive loss of blood volume and protein. It acts like a factory manager, frantically overproducing everything it can to thicken the blood back up. It churns out massive amounts of cholesterol and triglycerides.
So a microscopic electrical leak in the kidney causes sky-high cholesterol. Wild. Okay, what about APG, acute post-streptococcal glomerulonephritis? It has a low-grade temp, elevated BUN, and severe high blood pressure.
APG is friendly fire. After a kid recovers from strep throat, they have leftover antibodies floating around. These antibodies bind to dead bacteria fragments, forming heavy, sticky clumps called immune complexes.
And they get jammed in the kidney filters, like hair in a drain.
Exactly. The immune system sees these trapped clumps and launches a massive inflammatory attack on its own kidneys, causing the fever. Because the drain is clogged, toxic waste like BUN builds up. And since fluid can't be filtered out, water volume stretches the blood vessels, causing severe hypertension.
And the third one, hemolytic uremic syndrome, HUS. It adds a severe drop in platelets to the mix.
HUS is an absolute nightmare, usually from an E. coli infection, which produces a Shiga toxin. That toxin enters the blood and specifically shreds the endothelial cells lining the blood vessels inside the kidneys.
Like microscopic razor blades.
Yes. As red blood cells try to squeeze through, they are violently sliced to pieces, causing severe anemia. The body responds to this massive internal bleeding by rushing millions of platelets to patch the thousands of shredded vessels.
The sandbags.
Right. But the body consumes almost its entire circulating supply of platelets just trying to patch the kidney. The child develops profound thrombocytopenia. Without platelets, they're at extreme risk of spontaneously bleeding into their brain.
Staggering. 3 entirely different ways to destroy a kidney. Let's move to the heart. An infant taking digoxin has a heart rate of 70 and has vomited 3 times.
Digoxin is a potent cardiac glycoside for heart failure. It slows the heart rate down, but makes each squeeze much more powerful. But its therapeutic window is microscopically small.
A heart rate of 70 is great for an adult, but bad for an infant, right?
Normal for an infant is 120 to 160. Heart rate of 70 means the digoxin has severely depressed the electrical node. But the symptom clinicians miss is the vomiting.
Yeah, parents might just think it's a stomach bug. Is the drug irritating the stomach lining?
No, the vomiting is a profound neurological response. Digoxin easily crosses the blood-brain barrier. Deep in the brainstem, the chemoreceptor trigger zone detects the toxic accumulation of the drug and fires an unstoppable command to the diaphragm to forcefully evacuate.
The brain is commanding the body to vomit because it senses it's poison.
Exactly. An infant on digoxin throwing up is a massive red flag for a lethal cardiac event.
Staying with the heart, a child with heart failure needs small, frequent meals. Why?
It's the massive metabolic cost of digestion. When you eat a large meal, the body diverts up to 30% of your cardiac output directly to the gut to break down the food. A healthy heart just beats faster to keep up.
But a failing heart has no reserve.
Right. If you force a weak heart to pump that much extra blood to the abdomen, the muscle tires out, fluid backs up into the lungs, and they crash into acute pulmonary edema. Small meals spread that energetic budget out safely.
Let's finish this section with the chiaxylate enema. The file says it's effective when the blood potassium level hits 4.1. How does an enema fix a blood problem?
Chiaxylate is a cation exchange resin. It treats hyperkalemia, dangerously high potassium, which can cause fatal heart arrhythmias. The enema is a thick liquid of resin molecules preloaded with harmless sodium ions.
You put it in the large intestine.
Yes, which is lined with millions of capillaries. The resin has a vastly stronger magnetic attraction to potassium than sodium. As the toxic blood passes through the intestinal wall capillaries, the resin drops its sodium and violently grabs the potassium out of the blood.
It's a chemical trading post across the bowel wall. And then they just poop the potassium out later. Brilliant. Okay, section 7, development, environment, and safe practices.
We have to remember you can't treat a 2-year-old like a miniature adult.
Right. Let's look at a toddler behavior milestone. Expresses likes and dislikes. To a parent, that just sounds like the terrible twos. Why is a tantrum over a blue cup a clinical milestone?
It's the monumental transition from infancy to toddlerhood, the stage of autonomy versus shame and doubt. Their prefrontal cortex is developing, and they realize they are an independent entity with agency. The birth of the word no.
So a tantrum is proof the brain is building a healthy ego.
Neurologically, yes. What about the 4-year-old cutting a shape with scissors?
Yeah, why is arts and crafts a medical benchmark?
To cut out a specific shape, the non-dominant hand must rotate the paper perfectly while the dominant hand operates the scissors and the visual cortex tracks a line. It requires immense rapid communication between the left and right hemispheres of the brain through the corpus callosum.
It proves the neural pathways are firing perfectly across the brain. Got it. Now what about the 6-month-old well check warning? Strabismus needs reporting. That's crossed eyes, right? I thought all babies cross their eyes a bit.
At 2 months, it's normal as the eye muscles strengthen. But by 6 months, if the eyes are still crossed, they are sending 2 completely conflicting images to the visual cortex.
The brain can't process severe double vision.
Exactly. So to survive, the infant's brain will permanently shut down the neural pathways from the weaker eye. It will stop processing that visual input entirely.
It turns the camera off to save the computer.
If it isn't corrected quickly, usually by patching the good eye to force the brain to use the weak one, the child will develop permanent cortical blindness in that eye.
That is intense. Okay, safe environments. Managing severe pain for a 1-month-old infant getting a heel stick for a blood draw. The correct action is to let the mother breastfeed. Using an ice pack is incorrect. Why is breastfeeding the ultimate painkiller here?
It's vastly more powerful than simple distraction. Breastfeeding is a multimodal neurochemical analgesic. First, skin-to-skin contact creates profound parasympathetic security, calming the heart rate.
Second,
The incredibly sweet taste of the breast milk triggers the massive release of endogenous opioids endorphins directly into the infant's brain.
the brain synthesizes its own morphine.
Exactly. And third, the mechanical rhythmic suckling activates heavy sensory pathways. According to the gate control theory of pain, the massive influx of comforting sensory signals from the mouth literally closes the neural gate in the spinal cord, blocking the sharp pain signals from the foot.
An ice pack would be terrible because it causes severe vasoconstriction, right? The nurse wouldn't get any blood and would have to squeeze the heel violently, causing a crush injury.
Spot on.
Quick rapid-fire scenario. An IV site is swollen, pale, and cool to the touch. The action is immediately turn off the pump. Why is it cool and pale?
Severe infiltration. The catheter slipped out of the vein, and the mechanical pump is forcefully flooding the surrounding fatty tissue with room temperature saline, which is much colder than body temperature.
The fluid pressure squeezes blood out of the local capillaries, turning the skin pale. Turning off the pump stops the mechanical trauma.
Yes. Always stop the pump first.
Okay, we are entering our final section, the hard conversations. This is where science meets the raw human condition. Let's talk about immunocompromised patients. A preschooler with neutropenia must strictly avoid daycare. What is a neutrophil?
The frontline infantry of the immune system. Neutropenia means they have a dangerously low count of these attack cells, often from chemo. If a healthy kid gets a cold, neutrophils wipe it out. If a neutropenic child gets that exact same cold, it escalates into lethal sepsis in hours. Daycares are biological mixing bowls of viruses.
Same logic for the chemo patient screening visitors, right? A scratchy throat for an aunt is a fatal pneumonia for the kid. Now, what about the 15-month-old with an anaphylactic allergy to neomycin? The rule is to withhold the MMR vaccine. Is neomycin part of the virus?
It's an antibiotic used as a preservative during the manufacturing process to prevent bacterial contamination in the viral cultures. It's just trace amounts, but for a kid with a true IgE-mediated anaphylactic allergy, injecting it will trigger massive mast cell degranulation.
The nurse is the final safety check. Let's move to abuse. Identifying physical abuse manifestations. The file highlights symmetric burns of the lower extremities. Can you explain the forensic mechanics? Why does symmetric mean abuse?
This is a somber but essential piece of diagnostic physics. When a toddler accidentally pulls a pot of boiling water off a stove, the burn pattern is chaotic and asymmetric. It has splash marks and teardrop trails running down the skin.
But symmetric burns
Indicate an intentional immersion burn. This happens when a child is forcefully held down and dunked into scalding water as a punishment. The water level of the tub creates a perfectly straight, horizontal line across both legs.
No splash marks.
Right, and you often see donut hole sparing. The skin pressed hard against the cool porcelain bottom of the tub doesn't burn, leaving a clear, unburned circle surrounded by severe, deep tissue burns. Recognizing that perfect geometry is the chilling, objective proof of abuse.
You have to read the terrifying story the burn is telling to protect the kid. Our final scenario is the hardest conversation in medicine. A child has sustained brain death after a bicycle crash. The clinical team is discussing organ donation. The file says the very first action is to explore the parent's feelings and wishes, not hand them a consent form.
This requires immense emotional intelligence. At the moment brain death is declared, you are no longer saving the child. You're trying to support a family whose entire universe has just been destroyed. If you walk in talking about surgical logistics or consent forms, you inflict massive emotional trauma.
You're treating them like a logistical problem.
Exactly. You must sit down, create a quiet space, and actively listen. Ask open-ended questions. Did you and your child ever talk about helping others? You have to understand their cultural background and personal values before any medical steps can be mentioned. The human connection must precede the clinical process.
What an incredible, heavy, brilliant journey we've been on. From air trapped in a chest cavity, crushing a lung, to the silent chemical mimicry of lead, to the emotional intelligence required to guide a family through world-ending grief. The synthesis required by pediatric nurses is just staggering.
It is the ultimate integration of rigorous hard science and profound empathy.
So, as we wrap up, I want to leave you, our listener, with a final provocative thought. AI is entering healthcare at a rapid pace. Algorithms can analyze 1 million lab results in milliseconds. But will an algorithm ever be able to replace the intuitive, brilliant leap a nurse makes when they look at a pale toddler, hear they're a picky eater, glance at the faint white dust on the parent's shoes, and suddenly realize the age of the house is destroying the child's brain?
Or will AI just become the ultimate background processing tool, freeing up the human clinician from the screen so they can spend more time sitting with grieving parents or noticing the symmetrical, terrifying line of a burn on a toddler's leg? That complex human detective work, that sheer empathy, that might be the one thing silicon can never replicate.
Something to mull over the next time you marvel at the everyday workings of your body, or trust it to the care of those who have dedicated their lives to understanding its chaotic mysteries. Thank you for joining us on this deep dive. We'll see you next time.